Good afternoon. If I could ask for your attention, please. Welcome to the meeting of the Assembly Committee on Health. I'm the chair, Bill Monning. We appreciate your being here today. Let me provide some updates before we start moving forward. As is our custom, each bill we will afford 2 witnesses in favor, 2 witnesses in opposition, and affording them 3 minutes each unless we've made prior arrangements. After that, we'll ask supporters or opponents to offer your name, your organizational affiliation, and whether you support or oppose the legislation that we are considering. Today, Assemblymember Norma Torres will replace Assemblymember Bonnie Lowenthal for today's hearing only, per the request of Speaker John Perez. On consent today, the following items are proposed consent. Any member of the committee may request that a bill be removed from the consent calendar. Currently, we have placed on the consent calendar AB 1761 by the Speaker and AB 2315 by yours truly. We've removed from the calendar item number 3, AB 1579 by Assemblymember Campos at her request, and that will be rescheduled at a later time. We do go in bill order. Our first presenter is not present, and so we're going to move to item number 6. We'll go first by presenters who are not committee members, and then we'll go to the bills by committee members. AB 1869 is being presented by a committee member, Dr. Pan, but on behalf of Speaker John Perez. This is item 6, AB 1869. Good afternoon, Dr. Pan, and the floor is yours.
Is that on? There we go. All right. Thank you so very much. Pull this up here. Chair members, I'm happy to present AB 1869 on behalf of the Speaker. AB 1869 simply directs the Office of the Patient Advocate to include information regarding federal veteran health care benefits as part of the information assistance it provides to the public. This bill addresses the fact that we have almost 2 million residents who are veterans here in California, many of whom, unfortunately, are not aware of their eligibility to collect federal veteran benefits, including pension and health care benefits, and certainly something I know personally as Vice Chair of the Committee on Veterans Affairs. And in some cases, health care benefits a veteran may be eligible for provide a more attractive health service option than existing state programs. This bill would simply require that a duty of the Office of the Patient Advocate, a very important office to ensure people know about their benefits, is provide information regarding VA health benefits so that veterans who contact the office are better informed about their options. So I respectfully ask for an aye vote and witnesses.
Beth Capel on behalf of Health Access California. We were pleased to sponsor your measure, Mr. Chair, to move the Office of Patient Advocate and substantially revise its duties in the light of the implementation of health reform. The addition of veterans is an important and worthy one. We're only sorry we didn't think of it last year, but we're pleased to support the bill this year.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, the co-sponsor of the Chair's bill, AB 922, last year. And the Office of the Patient Advocate is truly designed to be a one-stop shop. So, of course, we want to make sure to serve the needs of veterans as well in support. Thank you, sir.
Thank you. We don't have a quorum established yet, so we will rely on you to circle back once we've established quorum. Any other witnesses in support? Seeing none, any witnesses in opposition? I just also want to we've just established a quorum, I think. So let's take a pause from the proceeding. We will do roll call, establish a quorum, and then we may be able to act on the bill right now. I'll ask the clerk to call the roll.
Monning.
Here.
Logue.
Dan, are you here?
Yes.
Amiano. Here. Atkins. Bonilla. Eng. Garrick. Here. Gordon. Hayashi. Hernandez. Torres. Mansour. Mitchell. Nestandi. Pan. Here. Perez. Silva. Here. Smythe. Here. Williams.
quorum is established. We have a motion. And we have a second. And Dr. Pan, would you like to close? And I want to thank you for representing the speaker today, and thank the Speaker's office and the supporters of this bill for making sure we are inclusive of our veterans community. So thank you. We have a motion on the floor. This is due pass and refer to appropriations. Ask the clerk to call the roll.
Monning.
Aye.
Monning, aye. Logue. Logue, aye. Amiano. Amiano, aye. Atkins. Atkins, aye. Bonilla. Bonilla, aye. Eng. Garrick. Garrick, aye. Gordon. Hayashi. Hernandez. Torres. Mansour. Mitchell. Nastandi. Pan.
Aye.
Pan, aye. Perez. Silva. Silva, aye. Smythe. Smythe, aye. Williams. Williams, aye.
That bill has 10 votes. It's out. Thank you, Dr. Pan.
Mr. Chairman, if I could move the consent calendar.
Yes, thank you. Do we have a second? We have a motion and a second on the consent calendar. Ask the clerk to call the roll.
Monning.
Aye.
Monning, aye. Logue. Logue, aye. Amiano. Amiano, aye. Atkins. Atkins, aye. Bonilla. Bonilla, aye. Eng. Garrick. Garrick, aye. Gordon. Gordon, aye. Hayashi. Hernandez. Torres. Mansour. Mitchell. Nastandi. Pan.
Aye.
Pan, aye. Perez. Silva. Silva, aye. Smythe. Smythe, aye. Williams. Williams, aye.
That has 11 votes. The consent calendar is passed. Has Mr. Allen joined us yet? Seeing no Mr. Allen, is Senator DeSaulnier present? Then we're going to move to member presentations. Item number 4, Ms. Bonilla presenting AB 1580.
I got it. Thank you. Thank you, Mr. Chair and members of the committee. Last year, the governor signed AB 1296 to implement the Healthcare Eligibility, Enrollment, and Retention Act to streamline and simplify the eligibility and enrollment in the public health programs. This year, I'm bringing forward AB 1580 to make some technical and clarifying changes to last year's AB 1296. The changes basically are to clarify the fact that the last bill unintentionally applied to too broad a group of people and required their application to be sent for a full eligibility review. This bill, AB 1580, limits the population whose applications are forwarded to only individuals with a disability that are 65 years of age or older, and this is now consistent with the ACA. And secondly, this bill, AB 1580, clarifies that presumptive eligibility shall only be granted as required by state law and to the extent permitted by federal law. The intent was not to grant presumptive eligibility to all new populations. AB 1580 corrects this as well. I'd ask for your aye vote, and I have Elizabeth Landsberg here on behalf of the sponsor, the Western Center of Law and Poverty.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty. We were pleased to sponsor 1296 with the Assemblywoman last year. As she's ably stated, these are clarifying amendments. Happy to answer any questions you may have and urge your aye vote. Thank you.
Beth Capella on behalf of Health Access, also in support of this measure as we were in support of last year's measure. Thank you.
Thank you. Any other witnesses in support? Any witnesses in opposition? Please come forward.
Mr. Chair and members, sorry, I'm on crutches and looking for them over there. Didn't think it would go so fast. And that also means I'm Sarah Nichols, SEIU, California, in support of the measure.
Thank you. Sorry to make you mobilize there without your crutches. Yeah. ACA. Any witnesses in opposition? We have a motion and a second. Committee members, any questions, comments? Seeing none, I want to thank you, Ms. Bonilla, for bringing this forward. And we have a motion and a second. Ask the clerk to call the roll. This is a do pass and refer to appropriations.
Monning?
Aye.
Monning, aye. Logue? Logue, no. Amiano? Aye. Amiano, aye. Atkins? Atkins, aye. Bonilla?
Aye.
Bonilla, aye. Eng? Garrick? No. Garrick, no. Gordon? Aye. Gordon, aye. Hayashi? Hernandez? Torres? Mansour? Mitchell? Nastandi? Pan? Aye. Pan, aye. Perez? Silva? Silva, no. Smythe? Smythe, no. Williams? Six needs 4.
That bill has 6 votes. It'll be on call. Needs 4 more. I see Mr. Allen has joined us, and so we will go to item number 2, AB 1569.
Can you hear me?
Yes.
Okay, great. Today I'm presenting on AB 1569, which would extend for another 6 years California's Assistant Outpatient Mental Health Treatment Law, also known as Laura's Law, so the counties have additional tools to treat severely mentally disabled individuals who have chronically refused treatment. Laura's Law was enacted in 2002, named for Laura Wilcox, a 19-year-old college student who was gunned down in Nevada County by a man suffering from a serious delusional paranoia. Specifically, Laura's Law permits counties to provide court-ordered outpatient treatment services for people with serious mental illness. To implement the order, a court must find that a person's recent history of hospitalizations or violent behavior coupled with noncompliance with voluntary treatment indicates the person is likely to become dangerous or gravely disabled without treatment. Scientific research strongly demonstrates that court-ordered assisted outpatient treatment services are highly successful for individuals with the most severe and persistent mental illness. In fact, numerous studies of New York's assisted outpatient treatment law, also known as Kendra's Law, has demonstrated reduced violence and danger, jail time, hospitalizations, and homelessness. In December 2011, the Department of Mental Health also released a report on the effectiveness of Laura's Law. The report found that hospitalization days decreased. No individual had contact with law enforcement. Most individuals were able to live independently, and all individuals were fully engaged with the program. It is also important to point out that despite the effectiveness of court-ordered assisted outpatient treatment, it is not a replacement for voluntary mental health treatment. We know that providing access to mental health services must be a priority. Compelling individuals to seek services voluntarily has an extremely high rate of success, particularly when adequately funded. However, we also know that some individuals fall into the treatment gap, those individuals who can't be compelled to seek services voluntarily, but who are not so gravely disabled that they qualify for conservatorship. Laura's Law is simply a tool to help provide this mentally ill population needed treatment. As demonstrated in New York and on a limited scale here in California, assisted outpatient treatment provides the legal and clinical treatment structure necessary to give certain severely mentally disabled people the support they need to achieve stability and a meaningful recovery. I have with me today Randall Hager with the California Psychiatric Association, as well as Michael Haggerty, Behavioral Health Director for Nevada County, which will speak in support of the measure.
Thank you, Mr. Allen. Witnesses in support.
Thank you, Mr. Chairman. Mr. Chairman and members, I am Randall Hager with the California Psychiatric Association. I'm going to just briefly introduce the issue, and then I'm going to cede the rest of my time to Mr. Haggerty because I think he's the star of these proceedings. He has hands-on experience with the law. This is really just a simple bill to extend the sunset. We have 2 counties who do have successful AOT implementation. That's assisted outpatient treatment, the concept behind Laura's Law. The legislative history here is that in 2002, both of the houses in bipartisan manner actually approved this measure, first in the Senate 27-8 and then the Assembly 73-4 in concurrence. Again, in 2006, we extended the sunset on this law. It was passed by the Assembly 65-11 in concurrence, the Senate 30-4. So that just says to me that this is settled policy. I know we may have a discussion about some of the policy elements today, but I just wanted to let you know that this body and both houses has considered this issue. The policy background is that in 1998 we had a wonderful program called the Mentally Ill Offender Crime Reduction Act Grant Program. Then in 1999 and 2001 we had the Homeless Mentally Ill Outreach programs. The statistics for both of those programs are fantastic. 75% of the people in both of those programs were had just amazing outcomes. The reductions in arrests, incarceration, in hospitalization, in homelessness were pretty staggering. Laura's Law was developed in this context and came along later in 2002. It also had what the other 2 bills for those programs had, which is a $50 million appropriation. However, that was when we were first starting to understand what the word structural budget deficit were beginning to mean, and that context of money was stripped out of the bill. I think if we'd had that money in the bill, we'd have seen much more implementation. But this is important to 2 counties. It's important for them to continue, and I think I will stop right there and cede my time to Mr. Haggerty.
Good afternoon, Mr. Chair and other members of the committee. I am Michael Haggerty. I live in Nevada City, California, and I work as the Nevada County Behavioral Health Director. In 2001, a person with an untreated mental illness shot and killed 3 people. Several other individuals were critically injured, including in the victims was Laura Wilcox, hence Laura's Law. After California enacted court-ordered outpatient treatment, known as assisted outpatient treatment, or AOT, along with 44 other states, Nevada County entered into an intensive community planning process. Part of that community planning process included receiving approval from the Department of Mental Health to use Mental Health Services Act funds, or Proposition 63 funds, to help fund implementation of Laura's Law. The community planning process included consumers, family members, our local chapter of NAMI, district attorney, public defender, superior court, law enforcement, treatment providers, and the hospital. After Board of Supervisors approval in Nevada County successfully implemented and began services in May of 2008. AOT is for people with serious mental illnesses that have already engaged in treatment unsuccessfully or refused treatment. These individuals have a history of either being violent or serious threats of violence towards themselves and or other people. They're not appropriate for other existing LPS laws such as emergency psychiatric hospitalization or LPS conservatorship. Without this law, there's no other way to engage these folks. Court-ordered treatment such as this is routinely done throughout the state of California in other venues, such as court-ordered treatment for individuals on probation or parole, LPS conservatees, mental health court and drug court participants. Our data show we've received 37 referrals and done 37 evaluations in the time since we implemented. 22 people engaged in treatment without a court process voluntarily. 11 court orders were written. Our outcomes show a significant decrease in both hospitalization and incarceration with the resulting significant cost savings. Other improvements were found by us in homelessness and in emergency room contact. Funding for this in our county is done with Realignment, Mental Health Services Act, Medi-Cal, Medicare, private insurance, and some self-pay. We found that for every $1 we spent on treatment, we've had a $1.81 reduction in savings.
You can finish your thought, or if you would please conclude, though. Thank you.
Thank you, Mr. Chair. AOT is a relatively low-cost front-end intervention that can greatly reduce the amount of money being directed into high-cost back-end services. It saves lives, it protects civil rights, it improves the safety and the quality of life for both the individual and the community. It fills a gap in the treatment continuum, and it allows for a less restrictive, less intrusive intervention instead of waiting for a person to have to be emergency committed to a locked facility. It's not a panacea, but it does support the possibility of engaging some individuals in treatment without which there would be no contact.
Thank you for your testimony. Now we'll hear other witnesses in support of the bill. And just a reminder, unfortunately, you do not have the opportunity to offer substantive testimony. Please, your name, organizational affiliation, and your support for the bill. We have a motion and a second. After the proponents of the bill, we will take testimony from opponents of the bill. So this opportunity is for those supporting the extension of the sunset on the current legislation. Your name, please?
For the record, my name is Nick Wilcox. I am the father of Laura Wilcox, for whom the bill is named. I respectfully ask for your aye vote.
Thank you for being here, Mr. Wilcox.
And I'm Amanda Wilcox, Laura's mother.
I'm Sharon Thorpe, the sister-in-law of Scott Thorpe, who killed Laura, and I'm very much in support of this law.
I'm Ken Murch. I'm representing the California Association of Psychiatric Technicians, and our organization is in support of this law.
I'm Susan Rajlal with Los Angeles County Department of Mental Health. On behalf of Los Angeles County, we support the extension of Laura's law.
Judy Rowland with NAMI California and California Hospital Association in support.
Jim Lindberg on behalf of the Friends Committee on Legislation of California, a statewide Quaker-based advocacy group. We're in strong support. Thank you.
Ernie Dahl, strongly in support of AB 1569. I'm the brother of a chronic schizophrenic and who didn't get the support, and I'm the father of a son who took his own life this December, also because of lack of support. Thank you.
Ryan Spencer with the California Medical Association in support.
Thank you. Any other witnesses in support? Seeing none, witnesses in opposition, and you're afforded 2 witnesses at 3 minutes each. If those primary witnesses would come forward to the table, please. Please come forward. There's microphones over at this end of the table. Please introduce yourself, push the button in front of you, introduce yourself, and there will be 2 witnesses afforded 3 minutes each. Thank you.
Good afternoon, Mr. Chair, committee members. Am I allowed as a witness to split my time with another witness?
We prefer that arrangement to be made in advance. The 3 of you have a total of 6 minutes, and the clerk will tell you when the time is up. You need to self-time. We'll give you each 2 minutes. Is that how you want to divide it?
Okay.
So we'll give a notice after 1 minute with a minute left in time.
Delphine Brody, MHSA and Public Policy Director at the California Network of Mental Health Clients. We strongly oppose AB 1569, and the reason we do that is, and with a large coalition of organizations and individuals from around the country that you'll see on the page 2 of the letter that we submitted. The reason that we do that is because not only would this extend AB 1421 or Laura's Law another 6 years, which we have opposed throughout the past 10 years, it will also remove state oversight of such programs. Involuntary outpatient commitment under AB 1421 violates or threatens to violate the fundamental human rights of a broad group of mental health clients with a history of hospitalization or suicide attempts by forcing them to comply with court-ordered treatment, even though they're not currently a danger to themselves or others. Involuntary outpatient commitment is inconsistent with mental health recovery principles of self-determination and empowerment. It's based on stereotypes, prejudices, and irrational fears of violent mental health clients. IOC uses coercion and risks re-traumatizing clients who have had a high prevalence of trauma and drives people away from treatment altogether. Finally, it threatens to divert scarce resources from voluntary mental health programs with a proven track record, such as Prop 63 full-service partnerships. We strongly support seeing these expanded and increased access. Thank you.
Thank you. Next witness.
Hello, members. Thank you very much. I'm Eduardo Vega. I'm the Executive Director of the Mental Health Association of San Francisco. I am a State Mental Health Oversight and Accountability Commissioner, and I am a member of the California Association of Mental Health Peer-Run Organizations. We strongly oppose this legislation and this sort of process actually going forward on the basis of several points, some of which have been mentioned. In addition to being stigmatizing and supporting discriminatory practices against people with mental health conditions, this is a measure that has failed the test of time that it was set up under Sunset to reach. So I think you heard people talking about 75% of their subjects for this program in Nevada County being treated. That 75% is actually 3. So the total number of people who have been treated under a court order in one of our smallest counties in California is 4. In Los Angeles County, the AOT program was deferred for purposes of court order, such that the people in Los Angeles County are receiving services under a principally voluntary basis. This is a bad policy to extend a sunset on a program that has failed to meet the test of time, that has shown so little implementation in only one of the smallest counties in California. California Council of Mental Health Agencies has opposed this. So has the Mental Health Association in California. We are mental health advocates. We support mental health programs. A wide variety of mental health program directors across California oppose this, and we strongly support that we not waste our time with this failed initiative.
Thank you. Next witness.
Thank you. Daniel Berzovich, Disability Rights California. Disability Rights California is opposed to the bill. I want to start off by saying I was surprised to read in the committee analysis that the bill applies to people who have been found to be a danger to themselves or others or gravely disabled. In fact, the bill expands the commitment criteria. It applies to people who are not dangerous or gravely disabled, and some of those people never will be dangerous or gravely disabled. We think that's a very serious expansion of commitment criteria and totally unwarranted. That's one of our worries about the bill, that we're establishing elastic commitment criteria. Another point I wanted to make about what's being presented as the success of the bill is that the studies that the legislature contemplated in 2002 to see if outpatient commitment really does make a difference have never been done. The studies would require a comparison between people receiving the same services on a voluntary basis and people receiving the services under 1421. No county has undertaken to do that, so we have an unproven model. I'd also like to point out that Mental Health Services Act funds are not appropriate for this program because those funds have to be offered on a voluntary basis, regardless of the legal status of the individual. And also, finally, one mention about the LPS task force. Well, we appreciate. Okay, thank you.
You can finish your thought, please.
Oh, I just wanted to say the task force was not an official task force, and their document is not an official document. Thank you.
Thank you, and I appreciate your accommodating our division of time there. Now we will move to witnesses in opposition. Please, your name, organizational affiliation, and I assume your opposition to the bill. Thank you.
Yes. My name is Deb Abbey, and I respectfully oppose this bill.
I'm Raylene Van Otten, and I respectfully oppose this bill.
Eva Nunez, connected with California Network and TLC, propose.
Good morning. My name is Katara Aslami. I'm the Executive Director of Peers Envisioning and Engaging in Recovery Services in Alameda County, and we reject this bill, and a vast majority of mental health clients do also, because it's coerced treatment that breaks the bond between trust between people with mental health disabilities and their service providers. Thank you.
I'm Ted Chapasinski. I'm an attorney from Berkeley and a member of Peers, and I oppose this bill very strongly.
Hi, Sharon Keene with Peers Envisioning and Engaging in Recovery Services from Alameda County, former director of the California Network of Mental Health Clients. I oppose this bill.
Good morning, Monique Tarver, Peers Envisioning and Engaging in Recovery Services. As a human being, consumer, and parent, I vehemently oppose this bill.
Yafa Alter with Peers Envisioning and Engaging Recovery Services. I adamantly, firmly, as a consumer and human being, oppose this bill.
Good afternoon. My name is Richard Krzyzanowski. I'm a founding member of the California Client Action Work Group. I'm also with the Mental Health Association of San Francisco, and I am a person with a psychiatric disability. I'm strongly opposed to this bill. This is not the kind of assistance we need. Forced treatment is not treatment at all. Thank you.
My name is Michelle Curran. I live in Amador County. I'm affiliated with the California Network of Mental Health Clients and also the California Client Action Work Group. I have long worked in the legislature, and I have long hoped that all services and all benefits to those of us who have a diagnosis are voluntary and healing instead of the coercive. So please, I oppose this bill.
Hi, my name is Stan Berrigan. I'm with the MHCC organization, and I tell you what really happened to me with this.
I'm sorry, we can't have you give testimony.
Oh, okay,
Do you support or
I'm
oppose
opposed
the bill?
this bill.
Thank you very much.
Joseph Robinson with the California Association of Social Rehabilitation Agencies. CASRA opposes this bill.
Hi, my name's Letia Lennis, and I'm with Peers and the Transitional Age Youth Advisory Board, and I'm opposed to this bill.
My name is Kimberly Marquez, and I strongly oppose this bill with Peers.
Hi, my name is Min Nguyen, and I strongly oppose this bill. Thank you.
Hi, my name is Mary Long with Mental Health Consumer Concerns, and as a consumer and family member, oppose this bill. Thank you.
Hi, I'm Joy Witt, and I'm with the MHCC, and I oppose this bill. Thank you.
My name is Nayura Sahib. I'm with Mental Health Consumer Concerns, and as a mother, a daughter, a grandmother, and a human being, I strongly oppose this legislation.
Frank Topping, speaking as a private individual. I'm Secretary of the Sacramento County Mental Health Board and a member of the California Network of Mental Health Clients, and I strongly oppose the bill.
My name is Robin Gutschall. I'm a mental health client. I'm with Mental Health Consumer Concerns. I'm a daughter, a mother, and a sister, and I oppose this bill.
Thank you. My name is Leslie Napper. I'm a consumer of mental health, concerned citizen and constituent, and I hope that you use our valuable resources to support and extend voluntary services. Thank you. I'm opposed.
Hello, I'm Charlotte Allen. I'm with the MACC, and I oppose the bill.
Thank you. Any other witnesses in opposition? I want to thank all the witnesses who have traveled here today for your presence and your concern about this legislation. And we will now open up to committee members' questions or comments. Ms. Atkins.
Thank you, Mr. Chairman. Mr. Allen, I just have a comment and a couple of questions. As stated by one of the representatives from the Disability Rights of California, in this bill, are you seeking to expand the criteria for the AOT program?
My understanding is the criteria is exactly the same that appeared in past legislation, that it does not represent an expansion.
Okay. Thank you. I have a question about the funding. There seems to be, are we using MSHA funding? I realize there's 2 counties that maybe use this as a tool, with your county being the predominant one. Are we using MSHA funding for this program, and are we allowed to use MHA funding for this program?
Nevada County is using MHSA funds along with a variety of other funding streams. We have written approval from the Department of Mental Health to use MHSA funds, and we have approval from our local Board of Supervisors and our local Mental Health Board.
Okay. Is that what I didn't recall MSHA, the language saying that it needed to be voluntary. Does it say that? Is there some discussion about this issue?
There is language in both Title IX California Code of Regulations and also a DMH letter that say that the programs and the services need to be voluntary in nature, but that a person's legal status will not prevent them from participating in the treatment programs. So our treatment program is commingled along with other individuals that are not court-ordered. You can't tell who's court-ordered and who isn't. And the legal mandate comes from the court. The treatment program is unlocked. There's no guards. There is no forced medication. There's no restraints. It's a completely open setting. Individuals go home at night, stay in their own houses, stay with their families.
Thank you. Mr. Chairman, I want to ask a question of one of the opponents. So if one of them will come back forward, one of the 3 individuals, fine. I will make my comment while they're coming up. You know, this is a tough one for me because I personally absolutely believe only in voluntary treatment. However, over the last 3.5 years, I've been doing a lot of homeless outreach or homeless surveys in downtown San Diego and interviewing homeless individuals. And the biggest concern I had was obviously people with a mental health issue that we couldn't even talk to. And some of them, over time, having participated in the program, I was very concerned for their well-being because I just couldn't imagine how they were existing on the street given the behavior. And I'm not a medical professional in mental health issues, but is there absolutely no way ever you believe that a tool like this used in very tightly constrained would be possible? I mean, do you really believe that there's never a time that someone should, to protect themselves, be put into a program that could eventually help them?
First, I want to take advantage of the opportunity to also respond to the question you just asked before, which I think is a very important question about the use of MHSA funds for these programs. Now, Nevada County has complied with the spirit, with the letter of the information notice from the Department of Mental Health, which is to say that they have not funded the involuntary portion of their services through MHSA dollars, or that's my understanding of the way that they approach this. It is clear in the statute and in the code that MHSA dollars should be used for people who may not be on voluntary status. That's to say, if somebody is in the hospital for a legitimate psychiatric crisis, they're under a 5150, there's no reason we think that should make them not eligible for MHSA services. But the involuntary portion cannot be funded. And then to go to your second issue, I'd like to just sort of reflect on an experience that I had. I worked in New York in a homeless outreach program specifically for people with psychiatric disabilities and mental illnesses. And one of the things that was really surprising to me, I was a sort of an early social worker, kind of a, real hippie, free, supportive person, was that we would drive up to people offering them peanut butter sandwiches, and they would run away from us. Not all, but some. They ran away from us because they had an experience with our agency as one in which we developed a relationship and then turned around and dumped them in the hospital, took their freedom away. Sometimes the result of that is that they lose housing and things like that as well. So that's, I think, the real issue with involuntary services is that the threats to a person's life and their future are really significantly diminished when somebody goes into a program involuntarily.
Let me attempt to answer your question, and I'm very concerned about people who need services, particularly people who are homeless. And we do have a system under the Lanterman-Petrus-Short Act to provide services to people who are a danger to themselves, a danger to others, or who are gravely disabled, that is, unable to meet basic needs for food, clothing, or shelter. And there is a Lanterman-Petrus-Short Act conservatorship that can last for up to a year and be renewed year after year for people who meet that criteria. What we're talking about here is an expansion of that criteria to people who are not dangerous or gravely disabled and never will be. While it's the same criteria that was in the bill that was enacted in 2002, still that's an expansion of criteria to people who are not dangerous or gravely disabled, and that's one of our.
I guess I don't see where it's an expansion. That you have to help me understand where it becomes an expansion if you are just extending the sunset of an existing piece of legislation.
It's an expansion over and above what the Lanterman-Petrus-Short Act provided.
But that was the belief at the time of the original legislation passing.
Obviously, you're all veterans. Okay.
In addition, there's also the removal of state oversight. That is, the State Department of Mental Health or its successor agencies' responsibility to evaluate and report on outcomes from all approved programs. That would be eliminated under this bill. I wanted to speak briefly in terms of my experience as a homeless person and the fact that I represent many homeless people in our organization. Thank you.
I do have to caution, as opposed to new testimony, it is our opportunity for members to ask questions.
Okay.
So if you can be very brief, we have a number of members who want to ask questions. So this isn't an opportunity for new testimony. If you can address the question of the member. Thank you.
In terms of Assemblywoman Atkins' question about homeless people's experience with coercion, and that was a huge issue for me during my time on the streets, and I scrupulously avoided programs that I thought would involve any sort of threat that I could be hospitalized, as did many of my friends. Since then, I've been working in this agency and others where I make countless contacts with people who have similar issues of trust. It's precisely the loss of trust that is the biggest risk that this program runs, that involuntary outpatient commitment is causing. And so we need to restore trust by allowing a level playing field and eliminating coercion. That's the basis of a mental health recovery system. Thanks.
Thank you very much. Mr. Chairman, just for the record, what I would say, I find this a very close call, given that I believe very much in voluntary treatment and that you do exactly what you've said, which is entice people over time through trust. I have to wonder if there isn't a point where that extra tool, if sparingly used, is not something that should be available. I worry about the people I've seen. I've been on the streets. I'm not afraid to talk. I'm going to go back to my folks that I've worked with very closely for the last 15 years and do a little more research. This bill is double referred. It goes to Judiciary Committee, I believe. I am on that committee, so I just for the record, because I think this is a critically important issue, and I'm not a veteran like some of my colleagues who've discussed this obviously at length. So I intend to support this today, but I reserve the right, after further discussion, to make a different choice when it comes before the Judiciary Committee. Thank you.
Thank you, Ms. Atkins. We have Mr. Smythe followed by Mr. Amiano.
Thank you, Mr. Chair. For the author and the supporters, do you have any reason why only one county, has implemented this, and certainly we understand it's the county where the incident happened and the tragedy occurred, but why is that?
Mr. Smythe, if I could, I think the clearest answer I could give you is the fact that I did allude to originally $50 million being in the bill in 2002. It was removed from the bill in the appropriations process. I think that if we had that money in it, you'd see 15, 20, maybe more counties who would have implemented it. Having said that, there is some difficulty in the language of the bill that makes it harder, from our perspective, harder than necessary, but harder for counties to look at this program and then try to find a way, as Nevada County has, to cobble together the funds to try to implement it.
And would you, I guess, explain why, as much as you can, briefly, that why the pieces in this bill or in this law are stronger than what's already in place, like in the Lanterman Act and others? I mean,
Okay, well, I'll take a stab at that, and then maybe Mr. Haggerty could also add to it. The fact is that Laura's Law is part of the Lanterman-Petra Short Act, so it's a piece. The advantages of Laura's Law are that it does provide for an outpatient commitment and it provides for early intervention. The advantages there should be obvious. People get intervened with earlier before they commit crimes, before they have to be hospitalized, before they go to the EDs. So that was one of the aims of the bill, is to provide a tool for some people who, because they are so sick they don't know they're sick, and if you don't know that you're sick, why would you ask for services? Why would you accept medication? Why would you go see a psychiatrist? For those people who continue to resist the admonishments of our very good outreach teams, we need to have a tool. And so I think Laura's Law does address that issue. And in doing so, it does save $1,000 a day of inpatient costs. It can avoid people going to the point of being conserved in counties, which is a very extensive, very expensive kind of process. It requires a county infrastructure to oversee conservatorships. So I think that's the way I would answer you at this point.
And if I could add, the 37 individuals that were referred to our department for evaluation didn't qualify for other existing parts of LPS. They didn't qualify for 5150 emergency psychiatric services. They didn't qualify for LPS conservatorship, 5350. So without this law, there was no way to engage those folks in treatment. One of the criteria of Laura's Law is that the person has already been offered an opportunity to participate in treatment, and they've refused. So just voluntary treatment, period, has already been tried with these folks, and without this law, there's no other way to engage them.
Okay, thank you for your, I have concerns. Obviously, this bill is already, the sunset's already been extended once in 2006, and now we're looking to extend it again. And in the course of that time, only 4 people have utilized the service in one county. And I don't have opposition to extending sunsets. We have, certainly in our time here. When I'm not sure I'm seeing the benefit of expanding the sunset, when you're not seeing the, and for whatever reason, whether the funding is not in place or not, I guess. That's what I'm wrestling with, is to extend a program that I have trouble with anyways, when we're not really seeing a significant amount of benefit. I don't know if maybe Mr. Allen could address the thought of moving forward with the bill, just doing the bill without a sunset, and instead of continually kind of going through this, because I know sunset's purpose is to review them after the sunset, and it's hard for me to see right now.
Well, that's possible, but it might also be part of some efforts that we might be doing in the next couple of years to look at the whole LPS law itself. I would say also that over the holidays, during the Christmas holidays, the Board of Supervisors in L.A. unanimously asked that the pilot project be allowed to continue. But I do take your point that maybe it's something that should be made permanent rather than continually sunsetting it, but maybe it should be done in the context of the whole LPS, looking at the whole act itself.
Right. But and just to respond, the LA County Board of Supervisors asked for several amendments to it as well that are not. So I mean, I get it. They'd like it expanded, but they'd like amendments to it as well.
Thank you, Mr. Smythe. Before we move to Mr. Amiano, I want to afford an opportunity for Ms. Atkins to introduce some guests.
Thank you, Mr. Chairman. I would like to welcome to the hearing Mr. Tom Gearing, who is the Executive Director of the San Diego County Medical Society, and I believe with him is their incoming president, Dr. Sherry Franklin, who are here today with a group of UCSD medical students for their annual student legislative tour. They were going to come in and meet with me, but here I am, so I invited them to come at least check out the committee.
Well, let me add my welcome, and we usually have a rule in here of no applause, but let's make a brief exception and just welcome you to Sacramento. Welcome. Thank you, Ms. Atkins. And now we'll go back to our rule. No applause, no boos, only respect. Mr. Amiano, the floor is yours with total respect.
Thank you very much. And, you know, there are no enemies in this room. And I have been around the block for many years around this issue locally in San Francisco particularly. I do think the polarity amongst the mental health community speaks volumes. You know, we really don't know exactly what is right. We're always in crisis. We don't have enough funding. Mental health has been the stepchild of health care, even health care reform. These concerns lead me not to vote for this today. I think you did touch on something, Mr. Allen, though, about looking at it more holistically. I think that's something that would allay some of my uncomfortableness, if that's such a word, around this issue. I don't see it as being effective. I do think that as chair of public safety, the committee members are very familiar in a sense with the thorniness of issues like this. I think about the sex offender arena and our visceral responses to that. There is no way we could ever match the loss of the families that were here today. I don't want them to think that they are being blown off or dismissed or trivialized, but there got to be a better way. And I'm hoping that like minds will come together. 10 years is a long time, and we still haven't been able to come to some consensus that is really based on effectiveness and fact, letter of the law versus spirit of the law. And so for these reasons, I won't be voting on this bill today, but I'm hoping that we don't neglect it, or if we have a Pyrrhic victory, the law is signed and the sunset is considered, that we just think we're finished, because I don't even think we're really beginning yet. I think we're trying to. I think the intent is indeed noble. So,
thank you, Mr. Amiano. Mr. Williams?
Well, my thought when I was looking at how few jurisdictions have taken advantage of it is more along the lines of that's maybe a positive thing, that I can see that this should be a strategy of last recourse, but a strategy that in some cases is necessary. And so to me, to see this in place as an option, a tool in the toolbox, but a tool that is not used very often, to me is a positive thing, and I will be supporting the bill.
Thank you. Ms. Hayashi.
Thank you. Thank you, Mr. Chair. Thank you, Mr. Allen, for bringing this important bill forward for a great discussion today. I have a lot of respect and admiration for the author. He's a psychiatric nurse and has done great work here. Unfortunately, I'm not going to be able to support this bill today because I serve on the Oversight and Accountability Commission, which was established by the voters' mandate when we passed the Proposition 63. And not only did I work on the initiative, I serve on the commission, and I've been on the commission since the very beginning. The OAC has voted to not support involuntary treatment with our funds, and that was the policy that we supported in the past. So just to be consistent with that in my previous position, unfortunately, I'm not going to be able to support the bill today. Thank you.
Thank you. Any other questions from members? Seeing none, just before your close, Mr. Allen, I would like to ask the sergeants to see if Senator DeSaulnier is available to join us. He's across the hall, chairing a meeting across the hall. And with that, Mr. Allen, we have a motion and a second. Would you like to close?
Thank you. Today, I don't doubt the sincerity of anybody who's testified before you today, and it is a difficult issue. And I think we would certainly, all of us in this room, agree that voluntary treatment is always preferable. However, I do feel this is a valuable tool. I feel that beyond the 4 people that were mentioned that were helped in Nevada County, part of the process of evaluation is to steer people into voluntary treatment whenever possible. I do feel that it's one valuable tool that is should not be lost in what we have to deal with. And I would point out that Kendra's Law, which is very similar and which was funded in New York and is a larger study, shows the utility and the effectiveness of keeping people from being homeless out of jail. And I do believe there, just like there is a right to autonomy, there's also a right to treatment when you are not able to make that decision for yourself. So I respectfully ask for an aye vote.
Thank you. There's a motion, do pass and refer to judiciary. The clerk will call the roll.
Monning?
Aye.
Monning, aye. Logue? Logue, aye. Amiano? Amiano, no. Atkins? Atkins, aye. Bonilla? Eng? Eng, aye. Garrick? Garrick, aye. Gordon? Gordon, aye. Hayashi? Hayashi, no. Hernandez? Torres? Torres, aye. Mansour? Mitchell? Nastandi? Pan? Perez? Perez, aye. Silva? Silva, aye. Smythe? Smythe, no. Williams? Williams, aye.
That bill has 10 votes. It's out. Thank you, Mr. Allen. Sergeants, any update on... Oh, he is here. Hello. Good afternoon, Senator DeSaulnier. Members, this will be item number 9, SCR 47, presented by Senator DeSaulnier.
Mr. Chairman, thank you. I'd take a long walk from across the hall to get some healthy exercise, and that'll be my segue into this resolution. SCR 47 requests that the Strategic Growth Council and its member agencies, departments, and offices of the Health Policy Task Force provide leadership on implementing the recommendations put forth in the Health and All Policies Task Force. The Strategic Growth Council was put together some time ago under the previous administration for better coordination and implementation of transportation and growth issues in the state of California, and under the leadership of both the public health officers and the former health director, Dr. Jackson, during the Schwarzenegger administration, the whole issue of not just smart growth and smart mobility, but also its impacts on public health and individual Californians' health, came up with a basically vision of how we could consider the implications of our land use decisions and transportation decisions on public health. And to that effect, they came up with this, the task force came up with this policy. It's merely meant to be a guideline in their consideration. A lot of work has been, good work has been done by the Strategic Growth Council, and we'd like to make sure that they use this good information to implement the suggestions. And with that, I have two witnesses in support, starting with Bruce Palmer.
Chairman Monty, members of the committee, Bruce Palmer, Health Officers Association of California, sponsors of the resolution. Just want to thank Senator DeSaulnier for his leadership, both previously at the local level in beginning this process several years ago and now with the state. I also want to thank Chairman Monning for his leadership in putting together the Prevention for Healthier California hearing. It's very much in line with what's being done here today. I also want to thank you for the comments you made in Budget Committee yesterday regarding the economic determinants of health. That's very important. I just want to say very briefly that this is primary prevention. This is affecting the conditions that affect health. As such, it's just good common sense when you do education, housing, and transportation policy. And once we move forward, I think we're going to begin to see some very important results in improved health for our citizens. Thank you.
Beth Capel on behalf of the California Pan-Ethnic Health Network. These impacts hit communities of color the most. We're pleased to be sponsoring two measures, including one by the chair and one by Ms. Mitchell, that arise out of the Health and All Policies recommendations, and are happy to be here in support of this resolution. Thank you.
Thank you. Other witnesses in support? Any witnesses in opposition? Seeing none. Committee members, questions? We have a motion and a second. Any committee member questions or comments? Mr. Williams.
Well, I support the bill. Of course, one of the things that I think we need to help is our local elected officials on the implementations of these kinds of policies, because that's where it's real hard, because everybody supports complete streets and increasing walkability, and especially for school children, until they have to slow down by 2 miles per hour or 3 miles per hour. And then they, then some people really then hate it. But I think as somebody who represents a community where, we've just lost a young person from, of course, that not having the proper level of walkability in a community, I think it's important for us to give those local electeds the courage and help to be able to do that, because our children's safety and pedestrian safety, I still think, is a more important value than for everyone to be able to drive everywhere as fast as they want. So I really appreciate you bringing forth the bill, and I'll be supporting it.
I also want to thank you, Senator DeSaulnier, supporters of this bill. Our challenge in promoting prevention and promotion of wellness is we have a healthcare system where the economics are oriented towards the treatment of illness and disease, and that's the most expensive and costly use of healthcare dollars, not to mention the impact on the quality of life of individuals. So I applaud you bringing this forward. Anything we can do to get health promotion and prevention into the front end of our public policy is going to not only save us dollars in the long run, but more importantly, contribute to more healthful lives and longer lifespans for California residents. So thank you. Let me offer you the opportunity to close, and we do have a motion and a second. So the floor is yours to close.
I appreciate all the comments. Assemblymember Williams does bring to mind, I did have a bill when I was in the Assembly that was vetoed by the previous administration. One of my criticisms of the Strategic Growth Council, having attended their meetings, is that there isn't a place statutorily for a local elected official. So I'm mindful that maybe I'll bring that bill back and you can be a co-author of it.
Great.
And with that, I would respectfully ask for your aye vote.
Thank you. And we have a motion and a second to adopt this resolution and refer to the Appropriations Committee. Clerk will call the roll.
Monning?
Aye.
Monning, aye. Logue? No. Logue, no. Amiano? Aye. Amiano, aye. Atkins? Aye. Atkins, aye. Bonilla? Eng? Aye. Eng, aye. Garrick? No. Garrick, no. Gordon? Aye. Gordon, aye. Hayashi? Aye. Hayashi, aye. Hernandez? Torres? Torres, aye. Mansour? No. Mansour, no. Mitchell? Nastandi? Pan? Perez? Aye. Perez, aye. Silva? Silva, no. Smythe? No. Smythe, no. Williams?
Aye.
Williams, aye.
Thought I'd get your vote, Mr. Smith. Smythe. Smith. Yeah, I know.
Members, that bill has 9 votes. It'll go on call.
I corrected myself.
They don't like to walk in Santa Clarita.
I'll start calling you the correct name when I start getting your support.
I'm only kidding. Thank you, Senator. Members, let me just give you a time check. We have 2 bills remaining. I'd ask the sergeants to please contact Dr. Pan. And in his absence, I will present AB 1526. That's item number 1. And I'd ask Vice Chair Logue to please chair while I present the bill.
Mr. Monty, please proceed.
Thank you, Mr. Logue. Members, this bill is related to 2 goals that I've had since I've become the chair of the Health Committee. The first one was to try to make Mr. MIP more affordable. My other goal was to actually meet Mr. MIB. I've been unsuccessful in the latter objective. But in my search, I have determined that this is an essential program, particularly now in this transitional period between now and the implementation of the Affordable Care Act. What we have is a subsidized insurance program run by the Managed Risk Medical Insurance Board for individuals with pre-existing medical conditions who are essentially uninsurable in the private market. The board is called Mr. MIB, and the program itself is called Mr. MIP. As you all probably know, depending on the outcome of the case being argued today before the U.S. Supreme Court, in January of 2014, insurers will no longer be able to deny coverage for pre-existing conditions. At that time, most people who are in Mr. MIP will be able to purchase insurance through the exchange. In the meantime, this bill does not help a little bit with my other goal, which is to make this program a little more affordable. It does help with that goal. It does so by eliminating the current $75,000 annual and $750,000 lifetime caps on benefits. I'd ask my witness, Ms. Asajian, from the Mr. MIB board, give you more specifics, but basically this bill means that a person with a catastrophic health condition will no longer have to pay thousands of dollars for health care costs, even though they have purchased insurance. Secondly, this bill eases some of the paperwork required to become eligible for the program. Both of these changes also bring Mr. MIP more in line with the federally subsidized pre-existing condition insurance program. And with that, I'd ask to present a witness in support, Ms. Asajian.
Do I have this on? Good afternoon, Mr. Chairman, members. I'm Jeannie Asajian. I'm the Deputy Director for Legislation and External Affairs at the Managed Risk Medical Insurance Board. Unfortunately, Mr. MIB was not available today and sent me in his place.
Thank you. The mystery continues.
He's shy. I'm here today to represent the board, which is in strong support of AB 1526. The Major Risk Medical Insurance Program, or Mr. MIP as we call it, is a comprehensive health coverage program for Californians who are unable to obtain health coverage in the individual market or are charged higher than normal premiums as a result of their pre-existing condition. Mr. MIP is administered by the board, but it is also a public-private partnership between Anthem Blue Cross and Kaiser Health Plans, and it is available throughout the state of California. The Contra Costa Health Plan is available in that county as well. Individuals pay Mr. MIP premiums that are approximately 1.5 to more than 3 times higher than the premiums paid in the pre-existing condition program. And they both share the same target population. First, I'd like to comment on behalf of our board on the provision of AB 1526 that address the elimination of the Mr. MIP annual and lifetime benefit limit. Based on data collected for the last Mr. MIP fact book, about 1% of subscribers reach the $75,000 annual benefit limit each year. Those who do not are by definition very sick individuals and in need of immediate medical services. When a Mr. MIP subscriber reaches the benefit limit, that individual must forego needed health care or incur financial liability for the entire cost of the services. I'm sure I don't need to tell you what these costs could do to an individual. Medical debt is a leading cause of bankruptcy. To make the situation even more dire, such an individual must continue paying their monthly premiums even though they are ineligible to receive any additional services for the remainder of that year. Annual limits are non-existent in California's mainstream commercial health market, and additionally there are no annual limits in the federal pre-existing condition insurance plan. Secondly, on behalf of our board, I'd like to comment on the provision of AB 1526 that allows submission of a licensed healthcare provider letter in addition to a letter of denial as proof of a pre-existing condition. By allowing Mr. MIP to also accept a licensed healthcare provider letter as evidence of a pre-existing condition, AB 1526 would enable applicants who are otherwise eligible for Mr. MIP to avoid unnecessary delays in obtaining coverage by seeking a letter of denial from a health plan.
You have to wrap it up, please. Go ahead and finish your comments.
For those reasons, the Managed Risk Medical Insurance Board strongly supports AB 1526. Thank you.
Second speaker, you have 3 minutes.
Beth Capel on behalf of Health Access California, also here in support. As the other supporter noted, it is rare for people to exceed the $75,000 cap, but we want to let this committee know that when it does happen, it is devastating. We had a case where a family with an adult disabled child had this coverage. They had 3 hospitalizations in the year. The first hospitalization, the discounted rate was $70,000. On the second hospitalization, which they were billed at the rate of $250,000, they were able to negotiate with the insurance company down to another $70,000, so they only had to pay $65,000 out of pocket. The third hospitalization, the hospital refused to negotiate, and they were on the hook for over $250,000. When these limits hit, they hurt, and they hurt very badly. People really cannot afford this kind of money out of pocket. This is an important improvement in this program that we strongly support. Thank you.
Thank you.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty and strong support. We've also assisted consumers who have hit the maximum limit, and it's devastating. Thank you.
Thank you. Witnesses and also in support.
Michael Richard with AARP California. We're very pleased to support this bill. Thank you.
Thank you. Any other?
Thank you, Mr. Chair and members. Teresa Stark on behalf of Kaiser Permanente. We're also in support today. Thank you.
Thank you. Any other witnesses in support? Witnesses in opposition? No witnesses in opposition. Members, any questions? Questions? That's for the roll call. You have to close, please.
Respectfully ask your aye vote, and I'm still looking for Mr. Mibb.
You pass and refer to appropriations. Roll call.
Monning?
Aye.
Monning, aye. Logue?
Aye.
Logue, aye. Amiano? Aye. Amiano, aye. Atkins?
Aye.
Atkins, aye. Bonilla? Ing? Aye. Ing, aye. Garrick? Gordon? Aye. Gordon, aye. Hayashi? Aye. Hayashi, aye. Hernandez? Torres? Torres, aye. Mansour? Aye. Mansour, aye. Mitchell? Aye. Mitchell, aye. Nastandi? Nastandi, aye. Pan?
Aye.
Pan, aye. Perez? Aye. Perez, aye. Silva? Aye. Silva, aye. Smythe? Aye. Smythe, aye. Williams?
Aye.
Williams, aye.
16 measure passes. Thank you.
want to thank Vice Chair Mr. Logue for sharing that bill. And now, members, we're moving to our last presentation, item 8, AJR 30 by Dr. Pan. And I'll remind you we have a couple of bills on call, and I'm sure others that members may want to add on to. So after the presentation and vote on this bill, I'd ask members to please hold your seats to vote on the on-call bills. Dr. Pan, the floor is yours.
Thank you, Mr. Chair and members. I present to you Assembly Joint Resolution 30, a measure that urges the federal government to add dental care into Medicare. A study published in 2005 by the State University of New York at Buffalo School of Medicine found that a major factor in seniors not obtaining dental care were financial barriers. And unfortunately, Medicare does not currently cover dental care. In 2009, adult dental benefits was also eliminated from Medi-Cal, enlarging the population of seniors who are not covered. Thank you. This resolution is designed to protect seniors from diseases. Our select committee showed that the poor oral health actually causes greater physical health problems as well, and that today I have as my witness Mr. Austin Lucero, member, senior senator from the California Senior Legislature, to here to testify on the resolution and help answer questions. Mr. Lucero.
Buonasera. Just getting your attention.
Thank you.
I'm Austin Lucero, and I'm a member of the California Senior Legislature. I represent seniors throughout the state of California, specifically in Santa Clara County. And I'm speaking in favor of AJR 30 because it's kind of a fix-it. What happened in Medicare, someone dropped the ball, and it's necessary for us to fix this thing. When they excluded or eliminated dental coverage in Medicare, they automatically included a lot of the concomitant things that happen when a person has a problem with oral health. I don't think it was done intentionally, but I think it's up to us to try to fix it. What this would do would, in fact, is put in the dental coverage back in to Medicare. Now, what are the problems? I personally am not an expert in medicine, and so in order to ensure the fact that I was giving you some correct information besides the research I've done, I contacted Dr. Swan, in charge of dental medicine at Harvard School of Medicine, and asked him some questions that were peculiar to this need. And what he said was that the impact of lack of coverage is huge, huge. He said it impacts things that are non-transferable, if you will. Things like respiratory disease, cardiovascular disease, diabetes, high blood pressure. Dr. Swan said also that it has effect if you have dental problems, has effect on folks that are pregnant, and when they deliver, the child is generally underweight. It could also be preterm. Dr. Swan said that dental problems and periodontic kind of problems are huge among young people, and they can be prevented. Even Kaiser and some of the other main organizations have already included dental care in their programs. AARP is advocating that folks start contacting the legislators in order to get them to sway their way of thinking so that they can do more of the things, that will help the seniors. So basically, I'm asking you to fix what went wrong somewhere and ask you to vote in favor of this. Thank you.
Thank you for your testimony. Next witness.
Beth Capel on behalf of Health Access California, also here in support. Thank you.
Other witnesses in support? Any witnesses in opposition? Member questions or comments? Yes, Mr. Nastandi.
Thank you, Mr. Chair. I appreciate the point of the legislation or the resolution, but I think it's tough for us to advocate to the federal government a position without the full context of what they have to wrestle with, which is the budget. So I think in a perfect world, we might want to do certain things, but they have the give and take that they have to deal with how they pay for that. And so, say a laudable goal, and as a doctor, I know you certainly understand that, but I'm hesitant to support something that doesn't have the full context of a full debate on the fiscal end. Thank you.
Any other comments or questions? I would just offer my support, and maybe with a slightly different angle than my colleague. This is a resolution, and what it seeks to do is to convey to the U.S. Congress the sentiment of hopefully a majority of the California legislature, and in making their tough decisions and balancing a tough federal budget, to understand that my sense is the intent of this legislation is to say oral health is part of health. And when we approach medicine as body parts as opposed to whole human beings, we end up with the body part that's not covered infecting other parts of the body. So I support this as an approach to health that would treat the whole human being and not body part medicine. So thank you for bringing this to us, Dr. Pan. Please, the floor is yours to close.
Just briefly, again, thank you, Chair Monning, for your comments, and I fully agree. And Mr. Standy, I think that certainly our federal government needs to consider things in the whole context. One of the things I'd point out, though, is that by not covering oral health, the oral health disease not being treated actually raises costs on the medical side. So I think we need to look at that trade-off, because we're probably paying more for respiratory disease, diabetes, and other things because we're having Medicare patients who aren't getting the oral health care they need. So I actually would urge Congress to look at that as well as a part of this approach. And I certainly urge an aye vote on this resolution. Thank you.
Thank you, Dr. Pan. And members, we have a motion to adopt this resolution. And I'll ask the clerk to please call the roll.
Monning?
Aye.
Monning, aye. Logue? Logue, no. Amiano? Amiano, aye. Atkins? Atkins, aye. Bonilla? Eng? Eng, aye. Garrick? Gordon? Gordon, aye. Hayashi? Hayashi, aye. Hernandez? Torres? Torres, aye. Mansour? Mansour, no. Mitchell? Mitchell, aye. Nastandi? Nastandi, no. Pan?
Aye.
Pan, aye. Perez? Perez, aye. Silva? Silva, no. Smythe? Williams? Williams, aye.
That has 11 votes. The resolution is adopted by this committee. Members, if you could just hold your positions for a moment. We have two bills on call, and we're going to start with item number 4, AB 1580 by Ms. Bonilla, and I'm going to ask the clerk to call the roll for absent members.
Eng? Eng, aye. Hayashi? Hayashi, aye. Hernandez? Torres? Torres, aye. Mansour? Mansour, no. Mitchell? Mitchell, aye. Nastandi? Nastandi, no. Perez? Perez, aye. Williams? Williams, aye. That's 12.
That bill has 12. AB 1580 is out. Our next bill on call is item 9, SCR 47 by Senator DeSaulnier. Ask the clerk to call the roll of absent members.
Bonilla? Hernandez? Mitchell? Mitchell, aye. Nastandi? Nastandi, no. Pan?
Aye.
Pan, aye. Has 11.
That bill has 11, and that resolution, it is out. And now, members, we will go to, let's just do consent calendar for absent members.
Eng? Eng, aye. Hayashi? Hayashi, aye. Hernandez? Torres? Torres, aye. Mansour? Mansour, aye. Mitchell? Mitchell, aye. Nastandi? Nastandi, aye. Perez? Perez, aye. That's 18.
Okay, consent calendar has 18 votes. Now we will proceed to add-ons. Let's just go in bill order, members. If I could have your attention so we don't have to go through this repeatedly. We're going to go to item 1, AB 1526. Clerk will call the roll of absent members.
Bonilla? Garrick? Hernandez?
Item 2, AB 1569 by Mr. Allen.
Bonilla, Hernandez, Mansour.
Item 2, AB 1569.
Mansour, aye. Mitchell? Aye. Mitchell, aye. Nastandi? Nastandi, aye. Pan? Aye. Pan, aye. That's 14.
Okay, item 6, AB 1869 by Speaker Perez.
Eng? Eng, aye. Gordon? Aye. Gordon, aye. Hayashi? Aye. Hayashi, aye. Hernandez? Torres? Torres, aye. Mansour? Aye. Mansour, aye. Mitchell? Aye. Mitchell, aye. Nastandi? Nastandi, aye. Perez? Perez, aye.
Bill has 18. Item 8, AJR 30 by Dr. Pan.
Bonilla?
You aye. She just called your name on Dr. Pan's AJR 30.
Yes.
There's a couple.
Bonilla, aye. Garrick?
There's a couple that you'll need to add on.
Hernandez? Smythe?
Okay. We're almost through, and then
I have 12.
Okay, that bill has 12. Okay, any other questions? Please approach the clerk if you didn't get caught in that run-through. And could the sergeant please contact Assemblymember Hernandez, Roger Hernandez? Is he en route? Okay, thank you.